At a systematic examination, a large number of problems may be discovered, but the question is whether the doctor that has discovered such problems may solve them. It's essential to direct patients through triage to institutions that may solve them. If the problem is glaucoma in children, we must react quickly. It's not the same as in adults. Pediatric ophthalmology and adult ophthalmology are different. If the problem is cataract, and there are many congenital cataracts, we must react, but not always as far as cataract is concerned. The attitude in the world doesn't suggest that every pediatric cataract must be operated. Only cataract that will disturb the development of visual function should be operated. Only a quite blurred lens that doesn't allow any light penetration. Such an eye will be an amblyopic eye, and if we wait for the child to start going to school and perform cataract surgery, then the problem will be solved, but the eye will be amblyopic, and we won't be able to activate all its visual potentials that can be activated if we perform surgery in time. The problem of dioptria is also our topic today, dioptria correction in patients from the youngest to the oldest ones. Why is it the most interesting topic? You see, this has been discussed, and professionals have worked on it for 15 years. We started to address these problems 3 years ago thanks to Professor Rudolf Autrata. As in other fields of ophthalmology, we tried to engage a surgeon who had achieved extraordinary results. We wanted to make it the last instance. He's one of the most cited authors in the world. He has dedicated a large study to this problem, and this is why he is superior. Immediately after that, we engaged him here in Sveti Vid. These problems were not addressed here in this territory of former Yugoslavia. They're still addressed in highly developed centers whereby a non-standard procedure is applied. It isn't performed everywhere, it isn't performed by every ophthalmologist, and it isn't performed by everyone who performs trabology, as it requires knowledge of laser correction, of the possibilities of laser correction. There are only 7 or 8 such centers in the world today. In Houston, Calgary, Washington, in Canada, and in Europe, such centers are located in Milan, Spain, and Sveti Vid in Belgrade. In fact, this is a refractive procedure for correction. We're talking about specific problems where the omission to react in time may lead to amblyopic population. I want to say that the fact that such a procedure isn't performed here does not mean that parents shouldn't be informed about it. This isn't a standard procedure, but there are centers in which it is performed. Perhaps you have 10% of children with such problems which standard ophthalmology can't solve. Glasses, contact lenses are good variants, but they can't solve. That's what I'd like to ask you. Should we wait when we notice that our child is amblyopic? Should we postpone the operation? Should the child wear glasses, or should the problem be solved immediately and forever? Glasses and contact lenses are excellent variants, but only if the child accepts them and if they can help. And they can help with some standard diopter values. However, laser diopter corrections are applied in situations in which glasses and contact lenses can't help, and if you don't do anything, the child will remain amblyopic. Why mustn't we wait until the age of 18? Because the development of vision is the most intensive between the age of 3 and the period when the child starts going to school. When do children undergo ophthalmologic examinations? When they start going to school. And the conclusion is that we've been doctors so far, we've established the diagnosis of amblyopia, but we haven't done anything to prevent it, and there are a large number of amblyopic children in our territory. Why? Because examinations weren't performed earlier, and let's suppose that such a problem starts manifesting itself at the age of 3. You have a child appearing at the ophthalmologic department of a health center, and the ophthalmologist establishes that the diopter value in one eye is -7 and that there's no diopter value in the other eye. And what does the ophthalmologist say? He says the child should wear glasses. You have a little child who has to get used to glasses. Further, it's impossible to put glasses with -7 and -1 because this is a great difference in diopter. What's happening? The ophthalmologist says, here's the prescription. They'll give you glasses in the optics shop. -4 and -1. You may put -4 or nothing. It's the same thing. Or he may say, close the better eye and make him see with his amblyopic eye. The child may see with his amblyopic eye, but only provided that it's totally corrected. How can you make a child whose vision is blurred wear a patch on one eye while he can't see with his other eye? You must make correction and then make the child use that eye in order to lower the degree of amblyopia and to prevent the development of high amblyopia. In this situation, which we call anisometropia, or great difference in dioptry in both eyes, contact lenses may help, but how are you going to make a 3-year-old child wear contact lenses? All right, if it's possible, I agree. What to do with the child who can't wear contact lenses? One shrugs one's shoulders. Okay, we're going to wait until the child is 8, and then we'll give him contact lenses. But it's senseless at that time. The eye is amblyopic. The period of the eye development is finished. What have we done? We've done nothing. We've closed our eyes to the problem that such a family will have to cope with their whole life. Laser corrections are obligatory in children in cases of a great difference in dioptry in both eyes and of high uncorrected diopter values. I'm talking only about situations in which we can't, regardless of how much we want it, solve the problem with glasses and contact lenses. Laser corrections are performed in cases of the so-called accommodative strabismus. This means strabismus, eye turning, which is a consequence of uncorrected diopter values, usually plus values, since farsightedness requires a too strong act of accommodation, and with this act you have eye turning, reflexive. All doctors know it, and in this case, good correction can straighten the eyes. What if you can't give glasses to a child? You must perform a laser procedure. Therefore, this is the third indication. The fourth indication is when you have children with special needs. What will you do with such children if they have Down syndrome, autism, or any other disturbance in psychomotor development, whose parents are dedicated to their children during 24 hours daily, working with them, trying to activate some vital functions, and you have additional problems with their eyes? Such a child remains in his psychomotor progress, but if he can't see well, he can't receive much information. You've deprived him of this information. You haven't given him contact lenses. You haven't given him glasses. There's laser correction. Therefore, it's not SVTV that has invented the application of laser. It has existed for 15 years, and it's applied in situations which were unsolvable earlier. In this way, we release the visual potentials of such a child, we enable such a child to sit normally at a school desk, we enable him to socialize with other children, to make friendships with other children, to acquire knowledge, to go in for sports, to make his own choice, to choose his interests and commitments on his own.
Sami svojom voljom neka svoja zanimanja I opredeljenja.